Good afternoon and welcome to another edition of SIF Virtual. I'm proud to be bringing you another interactive case review, and we really do have a group of superstars today on this. My co-moderator for this session, Dr. James Hermiller. You all know Dr. Mike Rinaldi, Dr. Carlos Sanchez, Dr. Steve Yakubov, my partner, Dr. Robert Burke, and two new additions to SIF Virtual. We have Dr. Srinivas Iyengar from Colorado and our new electrophysiology director at Honor Health, Dr. Rahul Doshi. Thank you all of you for taking the time out. I think this is going to be a great SIF Virtual session. Herms, I think I'll turn it over to you.
All right, sounds great. Srini, we're looking forward to this. This will be terrific.
Great, guys. Thanks a lot. And let's go forward here. And realistically, I'd like to present a real cool case for everybody watching that is interested in doing Watchman or is currently doing Watchman of how to navigate difficult anatomies. So that being said, let's move forward. There's my disclosures that you can see there. So this slide is something that we've seen it's well documented. Dr. Reisman has shown this previously, and what this really emphasizes to everyone watching, how the left atrial appendage can appear upon its gross anatomy or its pathology. You can see that, we try to reduce the appendage in terms of Watchman into certain vegetables or certain types of anatomies, but you can see clearly here, no one or two appendages look alike. And you can see here the differences that are present. So this is just something to keep in mind when you're doing your estimation on TE prior to implanting your device. So the variations of the left atrial appendage can be complex. Even if you have done hundreds of these devices, it can be very surprised by the anatomical differences that is present. So never assume a one-size-fits-all mentality, because again, not everything falls into the windsock, chicken wing, or broccoli category. And as I showed you, gross specimens can differ tremendously. So non-invasive imaging. TE has been the gold standard, and CT reconstruction has been very useful as well. But at the end of the day, the device is still deployed via a catheterization. So we know that LAA is dynamic and dependent on fluid status of the patient. I have actually personally seen firsthand, being that I live at altitude now, that I've actually seen appendages that were smaller on the TE grow on the table with contrast injections. So it's critical that your entire procedure plan is not only based on non-invasive assessment, but you have more than one size of a device available in case you need to go larger. So let's give you a background. We have a 76-year-old male with a past history of PAF, ischemic CVA, hypertension, heart failure, with a recent intracranial hemorrhage while on anticoagulation therapy. CHADS VAS score of 6. The pre-Watchman TE performed, which revealed measurements that were suitable for the device. However, the study was limited. This pre-TE was not done with anesthesia. It was done with, I think, conscious sedation, and there was some movement of the patient. So the echocardiographer had some difficulty getting the 135 view. I think this is an important point first and foremost. Don't cut corners when you're assessing patients prior to the procedure. The 135 degree was limited, and there is a reason we use 4 views in Watchman cases.
So Srini, can I just ask you one question? Do you use CTA, cardiac CTA much at all?
We actually do not use it as much because I think it's very, it's variable. When I've used CTA in the past, and again, I've become a fan of it, but not so much so that's supplanted my use of TE. And I know that certain sites have gone, quite honestly, to CTA first. How about you guys? Is there anybody in the panel that feels CTA should supplant TE?
Yeah, Steve?
I don't know if it's a question of supplanting, but I think you have to realize that they can tell you 2 different things, right? I mean, there's no doubt that just overall CTA gives you a bigger number than TE, right? And part of that has to do with the measurement plane, and Bob can probably comment on that more than I can, because sometimes the measurements that are made on TE are very different than the osteal measurements that you get on CT. And then there's other factors as well, right? And you mentioned the sort of growing and fluid status during a case, but there's also the issue of edema that can be affected by trauma. And that's certainly actually in the EP world, we see all the time with catheter ablation around the orifice of the appendage.
What I would say on TE versus CT is really you're dealing with the traditional recommendation for Watchman imaging based on 2D planar imaging. That's always going to be a limitation. And that's problematic. We used to do that once upon a time for valve sizing for TAVR. You know, once upon a time, that was our go-to. You'd get an LVOT diameter, and that determined your valve size. We all know that that is fraught with peril, invariably underestimates what size device you need, and you have to really think about it. They've done a better job with Watchman because, again, there are 4 measurements that we're using, so you really are attempting to get the biggest diameter that you can. In our lab, we use a lot of 3D TE, and we'll actually do a 3D reconstruction and actually measure around the virtual annulus of the left atrial appendage in much the same way that you will with CT. We've had some challenges with CT, just like you have, Srini, because there's inconsistency with really how you're supposed to make the measurement. Not all the radiologists do the exact same thing, and even some of the specialists have doubts as to where we really have to measure this to really be along the long axis and get a true short axis measurement of where you're going to be working within the left atrial appendage. Just like you said, the anatomy is highly variable. It's not always going to sit by the same set of rules.
So, and I would say that, you know, I think imaging is going to be very institutionally dependent. So if you have a strong CT, then that might be the way to go. If you don't have strong CT and you have strong TE, that's the way to go. In our institution, we have really strong structural TE, and we have, you know, superpower CT through Marcus Shear. And so we did a comparison, and it actually matched up to D.D. Wang's analysis when they looked at CT, and CT sort of makes it about 2 millimeters bigger on average than TE. And then the depth is pretty similar. When we looked at our own sort of comparisons, CT was a little bit better, you know, and we have great CT, so take it for what it is. CT was a little bit better at predicting the actual device size that went in than the actual TE on the table. It was actually a little bit more predictive. But again, if you don't have great CT, then it's not going to be your go-to study.
Well, great point, guys. And I think basically at this point, I think it's an evolving field, obviously. So I assume we're going to probably see more utilization going forward. But going back to the case, you can see here that the pigtail is obviously in a distal lobe, but again, it's deceiving because for everybody watching that, again, is starting to do Watchman implants, I think it's important to understand the difference between usable depth and actual depth. So you can see here on the TE, obviously, where the measurement was done pre, as we know, by numbers, this is adequate for placement of device, but by visualization, we can all tell it really doesn't necessarily mean you can put a device that deep into the lobe, knowing full well that might be too thin to place a device. And I'd like to point that out because this is pretty much what I thought we were dealing with in this case. That finger being the pointer where we were actually seeing the depth, and the knuckles actually being the rest of the lobe. So this is what type of lobe I can't really describe other than what I just showed you there with the picture. But I think that exemplifies the difficulty in just using the depth by number on TE versus what you can actually see.
Yeah, I actually think it's shaped more with a middle finger on this one.
Yeah, that's kind of what I felt like after we did this, actually, after seeing that. So I felt that I was a little bit against the grain on that one at that point. But again, with the depth measurement and non-invasive assessment, we'll often try and get width and depth with certain views and angles. There's a reality of usable versus actual depth. And I think this is something that a lot of people forget, that when they're starting out doing Watchman placement or Watchman, when I go out and proctor, I often tell them just because you have the numbers doesn't mean you can actually put the device in safely. It's critical to understand that not all depth is created equal, and curvature and narrowing are considerations that may limit the device deployment, as the current generation of Watchman devices require leg expansion. Now, again, we're not going to get into the conversation of flex at this point for this particular talk, but obviously that's going to change a lot in the next couple of months.
Srinivas, after seeing your angiogram, at that point, if you didn't have a CT, I would have really wished that you had a CT.
Correct. And I did at that time, thinking exactly that same point. I said to myself, it was one of those where, you know, as many as these that we have done, you find yourself relearning sometimes, you know, after a few hundred cases to say, I should have done this before. you know, and I actually felt the same way. So I think you can always learn something new during these cases. So guys, we went ahead with the deployment. We went with the double curve sheath. The transeptal had been clean, uneventful. So again, that's something, a take home point here, that was the first line of defense to make sure that our transeptal was done properly. The appendage is dynamic and can grow. So we decided to go with a 30 millimeter device. The reality of the usable depth became the underlying issue in this case. So here's the deployment of the device. And just by looking at alone, I think we can all tell the legs are not expanding. And just by this alone, without any angiography or TE performed, you can just tell by looking at it, it does not look like it's expanded well at all.
Srini, what did you get for your measurements that you chose that 30? I missed.
I was about 25 in the width, the osteal width, 24 to 25, and it looked like I actually love using my catheter width once I get in there and plump it up with an angiogram, and then I measure the catheter width because it's about 5 millimeters for the width of the catheter, and it came out to a high 27 or low 30 is where the measurements came about.
Yeah. Anybody do anything differently? I think that's just what I'd choose too.
Yeah, you're pretty deep though in there. You tuck that thing way back in the lobe. I think you're not giving it a chance to expand either by the lobe but I think the sizing is perfect.
Yeah, right, and I think we all know that, you know, the deep deployment, I mean, obviously there's always risks with these legs deep, but at least you can recapture and partially bring it back as opposed to being too proximal. My concern here was I just didn't want to be too proximal where I then had to get a new device. And I think my discussion a little bit later, I think will emphasize to people watching about the importance of not just trying to put a device in and then finding out you don't have another one on the shelf to replace it. But you can see here clearly with the angiogram, we missed the entire knuckle of that fist with that finger. So we got the finger, but we didn't get anything else. And that's pretty much what it looked like. So I think we capped off the finger pretty well, and we're left with the knuckles. So basically, yeah, this was not an easy picture to find. I'm glad I got it actually, because I think it emphasized what we did pretty well there.
So, can I ask you a question? Were you holding a lot of anterior torque?
Yes.
Okay. So, I mean, it's almost intuitive that you want to do that. You want to get in that anterior lobe. You want to maintain coaxial as you come back. But this is exactly the case, as was mentioned. You start distal because you want to be able to partial recapture, and that's fine. But holding that torque in this case, obviously, you're not going to cover posterior. And the device is going to be constrained anteriorly as well. So, no, I think this would have been a case where I might have actually just let go and let the dual curve do its thing as I was coming back. So,
and you're absolutely right. The tension on my finger, my hands, I think this is the unteachables. I hate to use that phrase. I don't even know if this is a word, but it's something you have to go through to tell someone how much torque or tension to have on the device while you're releasing it. And it's an experience issue. I really believe you just have to go through it to see how much you're actually putting on the device when you're releasing it. And again, as you can see here, we were obviously too deep, too compressed, and it looked like a jalapeno, not a strawberry in a fluoroscopy. There was obviously contrast going around the device, and no amount of tugging could get the device to expand further. But it was not all lost. Remember, we did say it was a deep deployment, so we performed a partial recapture. So here initially, you can tell here is the tug. Actually, the first recapture, I'm sorry. This is actually a first partial, and you see we are maybe a little bit covering that area, that knuckles, but again, we still clearly have flow around it, so it's definitely not covering enough of what we need to. So we performed an additional recapture, and here, I think we all realize it's not sitting. Now the face of the device is actually facing towards us, so it almost looks like it canted completely, though it's covering the ostium of the mouth of the appendage. I would tell you, for people who are novice at this, looking at this, they might look at this and say, hey, you've covered the appendage, but I think we all realize it almost looks like it's half out and it looks like it's canted. And obviously, are you guys worried by just looking at this of where the placement is?
Yes.
Very worried. Yeah.
Absolutely. And that's why I think the key is, thank God, you know, obviously we have the retrievability of the device, so that gives us the options. But under TE, you can see here too, it's not the device, it looks like it's on its side almost in this view here, actually.
Yeah.
Yeah, it's
It
completely
really does.
canted.
Yeah,
And
I
then,
really
look at, and then clearly at the TE view here, I think we can tell that there's still a very open gap that's still present, even being canted the way it is. So
now I'd really be worried about your size, Srinivas, because there's nothing that keeps the shoulders from being expanded and angiographically, and all of a sudden you're missing a whole posterior lobe or posterior placement.
right, exactly. There's your live feed there. You can see clearly that gap. It's massive. So we missed that entire lobe, even though it's canted out. So again, this is one of those cases where at this point, guys, how would you guys approach it at this point?
Mike?
Yeah, this is a tough one. I'm just not. So I'll be curious to see how you make this work. I think that upper lobe is, you know, there's a sort of fenestration there's a plaster wall that splits that appendage in two, and it's going to be very difficult to get those feet to expand. So the question is there a way that you can not use the depth there in some other way? Because I just don't think those feet are ever going to expand in that position back there.
You know, one other thing, Herms, is that once in a while, you know, we're usually committed to deploying off of the anterior lobe, but sometimes you have to give it up and try to deploy in an angulation that is more suitable to the left atrial appendage. And I think sometimes that's where CT really helps you. So I think in this case, if you're committed to the anterior lobe, you're probably not going to get this done.
And Srinivas, the other thing is, if you're trying to, as you put the next device in, and you're trying to buy depth on that anterior lobe, when you're about to deploy, take the anterior torque off. Just let it go a little, and it will be maybe do a more coaxial deployment and not so deep.
And I agree. I actually looked at this and I felt quite frustrated at this point, but I realized how much tension and torque I had on my hands while I deployed the device. So going forward, what now? So these are the questions I asked myself at this point. Were we really seated with the sheath properly? How much torque was on the sheath prior to deployment, and were we losing it during the deployment? Were we happy with the size of the device? Was it the transeptal stick that was limiting us? Do we stop the procedure and stick to basics? We didn't want to jump outside the box to do a double Watchman implant, as you know, we've seen reported that in these large, ultra large appendages where someone puts one in the bottom and the top. This was not one of those cases where I felt this could actually be suitable for that. So I felt at this point in time, we really had to reassess. So what we did is we went through a methodical approach. And I really believe that this has to be how the approach of every case, no matter how many you've done. We started back from the first step and worked upwards. We re-looked at the TS stick. We were happy with the transeptal stick. So we decided there was no need to re-access. The sheath torque, though, was significant. Mechanical loss was definitely occurring during deployment, during the fact that my hands were actually deploying it. Something mechanical was occurring. So we were not even sure we were seeing the distal end of the lobe either, because on TE, we were being told something different than we saw in angiography. The device upsize appeared suitable. However, we just needed to seat this better, and placing a 33 device was not an option because I don't think I had the depth. So though it was on the table, we decided not to go that direction. So what we did is we exchanged the sheath. So for everybody watching at home who can see this, why would you exchange sheaths? Well, an anterior sheath basically is a rightward lobe is utilization. A posterior leftward lobe, you would utilize a single curve. So we switched out for an anterior curved sheath. But again, it's not hard science here. I think a lot of times these appendages will deviate left and right, so you may have to play around with the sheath choice. We reseated the pigtail in a distal lobe. The sheath was able to be placed more distal, but it's not exact science again. And as an interventionalist, I live in a 2D world. But again, lobes don't always follow the 2D pathway. So we need to have all three types of sheaths available. So whoever's doing procedures, having just a double curve on the shelf isn't good enough. And I would show you here now with the anterior curve, look at how distal. Now that finger doesn't look as straight And the picture that I can use to verify how that looks now would be this. So rather than that finger sticking straight out, there was kind of a hump in the middle of it. So if anything, that might have been throwing us off when we were trying to deploy the device. So that gave me a little bit more information. And the anterior curved sheath, for me, at least personally, gave me a little bit less flexibility on the catheter and less tension and torque that I was putting on the device.
Let me ask you a question. Did you change the angiographic view at all? Occasionally in these really tough cases, just, maybe an areocranial, and another view gives you an insight that you otherwise didn't have.
Well, again, that's a great point, because I stayed in the areocaudal through deployment, but then I swung to areocrani for more of an osteal look at the device after I deployed. So we'll get to that next, but you're right, because I think we stick in the areocaudal excessively without looking at other views sometimes to give us a little bit more of an angulation if the appendage is difficult to deploy the device. So this is what we had on the initial, or the anterior curved sheath. So what I went forward with was a 30 millimeter device. I had less torque on the sheath while I deployed. Also, due to what I had just gone through, now what's the definition of insanity is doing the same things over and over, expecting a different result. Naturally, we changed a major factor here. We went from a double curve to an anterior curved sheath, and I decided to pull the system back with the knowledge that I could lose this device and I would have to pull another one off if it was too proximal. But before I did this, I checked my shelf. What was my stock? I had at least 3 other 30s on the shelf, so I was fully aware that this wasn't the last case of the day. I didn't go through all my supplies. I had enough to go if I lost this device too proximal. So again, the key point is we had multiple devices of this size on the shelf, so this was not the last try for this deployment. And this is how it looked after deployment. And what this was is from a very proximal, less torque on the sheath deployment. And the next shot, you can see a T obviously looks a much happier placement of where it is across the ostium. And let's see here.
So the feet really expanded.
Right. And when I pull back, and here's your 3D view of it as well, and you can see it there. And I want to go back to that one slide, see if I can show that. And you can see here where it looks like across. Yes, it's a little bit of a shoulder, but you know what? In this point of the case, I was happy with it. And honestly, as long as I wasn't seeing any significant leaks around that area, I didn't really have an issue with it. And again, going back to that 3D view, obviously, I liked how the face looked at the device. So I was quite happy that we got this far without a complication. And the deployment, we basically went through the pass criteria. It looks suitable by position on angiography and echo. Tug test showed no movement, and I'm an overcompressor. I like to compress between 15 and 25, so I was quite happy with this. There was no color around the device, and it was deployed without issue, and at 45 days, it was in place with no repair device leak. So the conclusion, which I really think is really important here, is to take your time, to stick to the basics and work around issues as long as you have the equipment at hand. This is a clear-cut issue of tactile frustration. I think we all have gotten there with coronaries, TAVR, whatever, Watchman. These are elective cases. I don't want to ever convert these to an emergent one. And I think we all have to have the confidence to walk away, and better to have a disappointed patient with no device than make a complication because of one. All right, guys. Any discussion? What do you guys?
That was spectacular. That was so instructive. I think that was just fantastic. Just one question, and we'll go all the way down the panel. As you deployed it, did you see it fall posteriorly, or did it stay up in the little, that?
It fell posteriorly, and I believe, just like it was discussed about the less torque. I think because again, some sites I've actually seen try to do a 2-man deployment on this. I do a 1-man deployment, so I had to have full control of the device. So I just took the risk of pulling it back while deployment, and it fell into the ostium very nicely.
Yeah, that's beautiful. Mike, what do you think?
Yeah, I like the concept of changing the angle of attack with the sheath change. I'm just actually still baffled and perplexed that the septum that was there sort of gave way and you had full feet expansion. I might have thought that it wouldn't have expanded, and I would have been completely wrong. So the appendage humbles me all the time. I always think I know what's going to happen, and then something different happens.
And Mike, that's a great point. And I felt like I told the lab staff, I tend to be very communicative with my lab staff and say, listen, if this doesn't work, we're walking away. We're not forcing something in. What I'm saying? We're not trying to force it in the hoop. If it doesn't go, walk away. We have an atrial clip program with our surgeons. They're very good at it. And again, I just feel like sometimes we tend to, as a proceduralist, force the issue of someone. And I think you can get yourself into trouble by doing that.
So we're about to start the option trial, which will allow us to have access to Flex. I don't know if anybody else has had any experience with Flex. I have not yet put it in. It's a totally different deployment, and it'll be interesting to see. It requires less depth. There's no feet at the end. It's probably safer. It goes in by balling it and pushing it in proximally instead of deploying it distal to proximal. I wonder if we're even going to need to screen these patients anymore, because so many of them it'll fit, and the safety may be greater. It'll be very interesting to see if this debate about CT or TE up front just goes away entirely and you just do them same day.
Mike, I think we would still screen just from the standpoint of thrombus, just to make sure you don't have an issue in that regard. And so I think we're probably not going to be able to get away with it entirely without looking. Even with therapeutic anticoagulation, we always get a case or two a year where there's a thrombus for reasons that really aren't anticipated, and then you find out that they haven't been taking their meds or something else. But I think we owe it to them to do a screen, unless you're going to be taking people off, maybe a couple of times a year, just because they do have a thrombus. There's going to be a balance there, I suppose.
I would actually make the point, coming from the EP side of things, that we have moved to uninterrupted anticoagulation for all these procedures, and you just don't see thrombus. As compared to interrupting NOAC therapy is a higher likelihood of thrombus formation than interrupting Coumadin therapy. I don't think there's any doubt about that, and we've seen this over and over and over again.
And Rahul, I'll tell you, that's a great point. I think that's amazing, because my EP partner, basically instructed me that he's like, why do you ICs only anticoagulate after you get the big sheath in? He's like, start the case, anticoagulate. And I was always worried about the transeptal, this, that, and other thing. And I've learned now, don't interrupt your anticoagulation, anticoagulate early in the case to avoid any untoward complication.
Yeah, I think it's just a function of we've all gotten so much better at transeptal than we were 20 years ago. I mean, I'll tell you, when I was looking at your choice and going with the 30, I am also equally amazed that Ed opened up and covered. I think it's an amazing case, actually. I do love the idea of going to a single curve with that anterior curve. That's exactly what I would have done. I was actually thinking 33, because the radial force, at least there was enough proximal depth before the lobe separation, where the radial force would still be more proximal, and you'd end up with a much bigger shoulder than what you had. So there's no doubt I would have had a lousier job.
No.
It's an amazing deployment, actually, for that anatomy. It's really a great job.
So, Srini, what was your pharmacologic marinade afterwards?
Well,
IC bleed, how did you manage that?
Well, it's interesting, because this is one of those cases where, I've talked to colleagues in other countries who've said, well, we don't put them on anything because this is the reason why we did the device. Obviously, we have the 45-day window here, and though the device-related thrombus rate is 3.7 or 3% rate right now, again, you don't want to be in that 3% rate. So it's a hedge. So what did I do with him? Eliquis 2.5 BID. I know it sounds like there's not really a lot of strong evidence either way, but I just felt so nervous about that intracranial hemorrhage, but I also had to be honest with the DRT rates. And so we hedged into the 2.5 BID. Again, I don't have any evidence to support that. It was just a gut feeling.
It's a really important point, because we're all aware of all the data from evolution and obviously from ASAP2 that we probably can get away with not anticoagulating these patients, right? And funny, now that we're all shifting to CT imaging for surveillance in this COVID-19 era, we are seeing, of course, smaller leaks and DRT. Now, it's interesting that the DRT that you're seeing doesn't appear to be increasing the rate of stroke or TIA. Right. So I think it is very different. It's going to be very interesting to see what happens with the new generation device, right? Flex doesn't have the same exposure at the distal screw, right? So it may not be necessary in general going forward. So
talking about anticoagulation, let's not forget that there's also not just the option trial, but the champion trial coming with Flex as well. Remember, this is going to be directly comparing DOACs to left atrial appendage occlusion. So that's going to be a very important trial as well in the armamentarium for it. So it's going to be ASAP 2 option and champion starting this year or continuing this year, which is fascinating.
Yeah. All right.
Herms, great discussion. Everyone, that was really superb. Srinivas, what a case. What a terrific case. I'd like to thank our panel of experts for joining us for this edition of SIF Virtual and Interactive Case Reviews. We have many, many more to come. And I would be remiss in my duty to Trish Gaffney and Gaffney Events if I didn't remind you there's going to be a lot more cases like this live and in person next March 10th through the 13th when we meet in Scottsdale again for Scottsdale Interventional Forum. So thank you very much to our panel of experts, and we look forward to seeing you again.